Thank you very much. It's a pleasure to be with you again. I had the pleasure to present to this body a few years ago on an area of my work that I think most of you are aware of in the population and community health and community benefit. And I sort of backed into working in the area of workforce and workforce diversity approximately 16 years ago. Began looking at this issue of health workforce diversity in California and was invited to participate in the then Institute of Medicine committee that produced the report on increasing the diversity of the health professions in 2003. In fact, a process led by one of our later panelists, Brian Smedley. And the key question and the reason I participated in that process was whether we should hold health professions education institutions more responsible for how they build a more diverse workforce of the future. In essence, should they do more than wring their hands about the incoming students not being sufficiently diverse by investing in building the workforce of the future in the communities in which they serve. I came out of that process, returned to California, and at the time our largest foundation, the California Endowment, was really looking at this issue and how to invest in it. And along with my colleague Jeff Oxendine, launched an initiative they supported that we call Connecting the Dots, that was in essence about developing a comprehensive strategy to build the health workforce of the future. I share this because we completed that study. We launched the California Health Workforce Alliance, and since that time that we completed that initiative back in 2008, we have convened diverse stakeholders across the state, employers, academic institutions, advocates, and others to look at ways in which to move this agenda. Suffice to say, our work is not done. And about a little over, just about 2 years ago, we were approached by our 5 largest foundations in California, who reminded us that we had issued a recommendation all the way back in 2005 that called for the development of a comprehensive health workforce master plan. And they asked us if we were interested in advancing that. Foolishly, we said yes. And what I'm about to share with you is the process over the course of the subsequent 2 years of the development of that, and the hope that it helps sort of frame and support the conversation that we're seeking to have going forward. So in the run-up to this meeting, with others planning this meeting, there were a number of questions that arose that I just thought I'd tee up to start us off. Some of them I will answer broadly in the subsequent slides that I'm going to cover. Others I think we will get at in the Q&A as well as in the subsequent panel discussions. But the core of it is how do we approach the issue of population health? How do we build the workforce of the future that better reflects our communities, that better prepares us in an environment where the traditional healthcare, the legacy healthcare systems are assuming increasing financial risk to keep people healthy and out of their institutions, where our hospitals are turning from being revenue centers to cost centers, and where it becomes increasingly important for our healthcare institutions to be concerned about a broad spectrum of issues in our community. And how do they do that? Who do they work with, and who else needs to be supported and have capacity built in this process? So these are the 5 foundations that supported this process. As you might imagine, each of them has slightly different priorities and areas of emphasis, but they came together, and I think this is a model for the kind of collaboration we'd like to see increasingly among our philanthropic community going forward. It is often needed to get to the scale and scope and focus that we need to achieve the kind of outcomes that we'd like to achieve. So the charge of the commission that was formed for the development of this plan was to think both in short term. There are many urgent demands in California as it relates to providing access to both health care, clinical services, as well as addressing the real drivers of poor health. And a really key issue, and I'll return to this along the way in our discussion in approaching this, was that this was not about coming together and identifying legislative solutions and solutions from the governor's office to this issue, that folks really had to come to the table ready to roll up their sleeves and look at how all sectors come together to address this issue. But the commitment was to get commitments not just for putting together a list, not just for putting together a report, but for putting together and engaging folks and securing their commitment to move forward with the process. And to think about this both in future terms, but how do we proceed towards that future? We have often in California become mired in a lot of traditional battles with our respective stakeholder groups over issues that get put on the table, and people almost reflexively fight against something that they, on behalf of their constituents, have told them that they would fight for. The idea here was to create the space for dialogue and for rationality, for data and evidence to drive the discussions forward in the process. So the commission landed on three core areas of focus: primary care and prevention, behavioral health, and healthy aging and care for older adults. There obviously are a broader spectrum of issues that one could take on, but it was felt that we needed to have some focus for the commission for this period of time, with the understanding that going forward with an implementation between 2018 and 2030, that other issues could be taken on. But these were felt to be the most urgent and driving. And as you see with a focus on diversity, continued emphasis on how to build the workforce of the future that reflects our increasingly diverse communities, a clear focus on equity. The most overriding issues in California is the maldistribution of folks in the health professions to serve particularly our rural and inner city communities, and to increasingly look at the role of technology in helping to drive these changes. So I'll depress you for a few minutes with some of the issues, the challenges that we face in California, some of which I think are clearly evident across the country. But we looked at all of these issues and the ways in which they interact. And the idea was to think comprehensively about what are synergistic kinds of actions that will help address multiple issues at the same time. So just a few data points. In California, in the next 10 years, we expect to have a shortage of about 4,000 primary care clinicians. I'm including not just traditional physicians, but also nurse practitioners and others that care for that. Up to 600,000 home care workers, and I'll come back to that shortly, and 41% fewer psychiatrists than needed. Currently, Latinos represent approximately 40% of our population, but only 7% of our physicians. As you see, 7 million of Californians live in health profession shortage areas. A majority of those are people of color. Our provider population ratios, particularly in those inner city and rural areas, are about 50% the federal recommended levels. You see one-third of physicians and nurse practitioners are over 55 and expect to retire in 10 years. Those figures are higher than that in rural areas. And then on the public health side, over 60% of folks who are the The senior leadership of our public health agencies are currently eligible for retirement, and over 95% of the funding for our state public health department is in categorical funding. So we're expecting an additional 4 million of us will enter the retirement age by 2030. This represents almost a 90% increase. Particularly striking to me in looking at these many figures is the percentage of these folks that live alone. Their children are, if they have children, are typically living in other parts of the country, and the real challenge is how do we ensure that they have the care. And then over half of them rely on Social Security for over 80% of their income. Again, I'm not, you have many of these in front of you. I just wanted to sort of tick some of these off to highlight how dire the situation is and why it became essential to take action. Particularly in the realm of behavioral health, we have a dramatic challenge as it relates to access to behavioral and mental health services in the state of California. And as you see, this is reflected in ED utilization and inpatient utilization across the state. We are under capacity and have underinvested in higher education in California for some years. We have relied on other states to do a lot of the medical education for our physician populations historically, and counted on them to come back to the state, given cost of living and a range of other issues. That is no longer happening. And so this is an issue that is a real driving force. I've noted here that higher costs and indebtedness in folks pursuing a medical degree tends to drive them towards specialties. But we also have a culture in our medical schools that still, and it leads to encouraging students to pursue specialties. It's just viewed as a more desirable path to pursue. We have, I think, the most extensive teaching health center GME training program in the country. We have 6 fairly qualified health centers that provide this training. And that does help ease some of the challenge, but our colleagues that run these centers say this, we're often put in a bind because as it is, the providers that we have are hard stretched to serve the populations that we have, and to do these programs, they have to step away from clinical care to provide the support for these students. In the realm of primary prevention, or as we increasingly call the social determinants of health, we have clearly some challenges that we're facing. Our homeless population has increased over 50% in the last 5 years, and as you see, we have almost a quarter of the homeless people in the U.S., close to 60,000 in Los Angeles alone. If you want Section 8 housing in Los Angeles, it's a 12-year waiting list, and then it's unsure. So we've estimated a need for an additional 1.5 million units of rental housing. That always becomes an increasing challenge when we look at the cost of housing and the overall cost of living. Close to 40% of our total population lives at or under 150% of what we have as the California poverty metric. This is adjusted somewhat upward, as you see 7,000, the federal poverty level, to accommodate the higher cost of living. And then in the realm of education, while we have preschool and a commitment to providing that, we fall well short of ensuring that for children. That's, as we know, is early on establishes the circumstances under which it is difficult for many of these children to pursue career in health professions, as well as an income that will support them and their families. While we focused on workforce, and you'll see throughout the report, continued focus on workforce, we had to acknowledge some of these dynamics, such as the issues that I just mentioned in the realm of primary prevention. But that at least as it relates to providers, we're 49th in the country as it relates to Medi-Cal reimbursement. If you're a provider and you're not tied to an FQHC, you are providing services at a highly discounted level. Technology is not equitably distributed across the state. And then we simply don't have the current capacity among our healthcare delivery system and the linkages to provide and extend the reach of our provider population to cover these issues in our low-income communities. And in order to move forward, it's clearly that we need much more investment in K through 12. So a quick run through the structures and process. We had a 24-member commission co-chaired by Lloyd Dean, the CEO for Dignity Health, now Common Spirit, and Janet Napolitano, the president of the University of California. The other commissioners tended to be decision makers, folks that could provide influence, folks that could command resources. So it's respective chancellors and presidents of higher education institutions around the state, the Senate and Assembly Health Committee chairs, and others that were in a position to weigh in on this. We had a 40-member technical advisory committee. These are our fellow mavens that work in the workforce arena that understand the issues, that could provide insights along the way with this process. And then 3 subcommittees where specifically to pull together folks that had particular expertise in the 3 priority areas of focus. The commission met 7 times between September 2017 and this last January. The Technical Advisory Committee, or the TEC as we call it, and the 3 subcommittees met numerous times during that process. As a part of the process, we also conducted a statewide survey to get input on an extensive set of draft recommendations. In April of last year, we had 177 recommendations. We ended up with 27, and some wished that we had less than that. But this was the challenge in putting together a comprehensive strategy that again, goes much broader than traditional healthcare to cover other sectors. The commission adopted the final report and 27 recommendations on January 15th. Among those, they weighed in and selected 10 in particular as top priorities for immediate implementation. And then what we're actively engaged now in the public report. In fact, while I'm presenting here, we also have a panel presenting in Los Angeles as we speak. Actually, a few hours from now. So these are just some of the elements of the deliberative process, just to show you that there was a lot of effort on the front end to release people to think broadly, blue sky visioning. Where do we want to go? We know we have challenges now, but let's step back for a moment and say, where do we want our institutions to be? What kinds of transformation do we want? And what do we think that's going to look like by 2030? And that enabled folks to step back and away from their battle lines to say, where do we want to go? So we went through a process where we convene the subcommittees, we dig into the materials, we bring it back to get input from the Technical Advisory Committee, then bring it back to the Commission, continue to refine, and then ultimately we had the co-chairs played a particularly important role towards the end of the process in helping to sort through and make some decisions and set some priorities. So we broke down the recommendations in 3 main areas, reflecting the need for a comprehensive approach. The first strategy one really focused on how do we create opportunities early on in the careers? How do we build the health career pathways from the very beginning to ensure folks have the opportunity to pursue higher education? Strategy 2 really talked about what are the changes that we need to make in the higher education process And then the third strategy really focused on how do we build the capacity, effectiveness of the current workforce to better serve our communities. So again, you have this available to you, the reports online, just to show you these are the recommendations in each of the three strategy areas. Those in bold are those that were selected as the top priorities in this area. So you'll see a broad spectrum and synergistic linkages between many of these, some focusing more on K through 12, some focusing more on higher education, but all having a real focus on equity, on addressing the fact that we have underinvested and underfocused in our rural and inner city areas and on populations who are typically underserved. Similarly, on our expanding education training to meet needs, again, you see the issues that folks felt to be most important. A major emphasis here on how do we draw people from communities that are underserved, particularly people of color, and how do we support them going back and practicing in these underserved areas at the end of their training. And then finally, and on this issue of building the capacity, effectiveness, and retention, you'll see that the top four in that and a number of others that were also important but weren't selected for immediate action. For folks like myself that both manage the process as well as a number of commissioners, I'll share that there's some frustration that we had such a focus on the delivery of clinical services in this process. It was difficult to get around in this process, in part because there was so much pent-up demand over all these years over how do we address our issues of primary care access, behavioral services, how do we address this issue. So you'll see the majority of the recommendations that were selected as top priority are in that area. I will note that scaling the engagement of community health workers, promotores, and peer providers was among those that were selected as a top priority, clearly an issue of challenge. And in this area and a number of areas, in addition to the convenings of the subcommittees, we convened groups of leaders on this issue. While we have a fairly extensive network of promotores and community health workers in California, for the most part, the engagement of these workers by our mainstream providers is relatively limited, as well as their roles are relatively circumscribed. So a lot of effort was seen. You will see in the recommendation for the process to scale the engagement of community health workers, significant emphasis on understanding the comprehensive role that community health workers can play, not just in managing the care of individual patients, but working in and with communities to really begin to address the drivers of poor health, including in working in the areas of policy advocacy. How do we address the spectrum of issues as it relates to quality of housing, indoor environmental factors, ordinances, the spectrum of issues that we want them to play in this process. So that was an important part of the deliberative process. I'll just note a couple other recommendations in here, and it's difficult to get a sense of what we're talking about here, but as you see, recommendation 3.9 to build the capacity of local public health agencies to support collaborative community health improvement. That involved in reflecting the commitment to shared ownership. That involved the state establishing a fund, making funds available if they are matched by local hospitals and health systems to directly engage someone with epidemiological expertise, preferably social epidemiological expertise, to begin to connect the dots in our communities between the range of activities going on, what many of us call the parallel play of each and every healthcare provider's community benefit programs and activities, to begin to work towards how do we focus and align these efforts in communities where inequities are concentrated? How do we begin to hold ourselves accountable for actually moving the needle on these issues? So a lot of these kinds of issues are buried in these recommendations, but reflected the commitment of the Commission to ensure that we're not just talking about changing the legacy healthcare system, but about how do we engage other sectors in addressing these issues. The community development sector, for example, and the ways in which we build relationships with them is critically important. So just last, I'll wrap up noting as we move forward, as I just referenced, there are detailed implementation strategies that are in the report. An important part of the last step in the process was doing not just budgeting this, but conducting impact assessments, which to some extent are limited by the availability of data. Some of the recommendations involve going where we haven't gone before. So we don't have a lot of data to tell us what the experience is. There's active dialogue. Upcoming hearing next week, we'll be presenting to one of the Senate committees on this issue. A number of legislators have stepped forward and offered bills on recommendations for this. And our 5 foundations and others are actively engaged in dialogue to look at ways in which they can ensure this process moves forward. A key issue is whether and what is the nature of a state infrastructure to ensure that this process moves forward, that there's facilitation and monitoring of the process in the years ahead. And last but certainly not least, ways in which we're engaging our employers and academic institutions to begin to actively look at what role they play in this process, how are resources allocated, and how are their priorities adjusted to reflect the recommendations of the report. So that was the process we pursued in California. Thankfully, that developmental process is done, and we are excited about moving this forward. With that, I'll stop and open it up for your questions.
Good morning. I'm sorry, I'm a little tall over here as I fight with the microphone. Good morning. Donna Grande from the American College of Preventive Medicine. I absolutely applaud your efforts.
Thank you.
This is important information, incredible data to take home, incredible alignment, and so it's a kind of a compounded question. Number one, how do you have the patience to wait for 2030 when you have some of the tragic data that you shared about 12 years waiting for Section 8 housing?
Right.
Number one. Number two, what would be those top 5 to 10 recommendations that you would say U.S. Congress needs to take action on in the next 3 to 5 years so that we don't wait so long, and looking at how we can build on your state accomplishments? And then number three, is there a way in your state efforts then that we could at ACPM align with you, because we're leaving over 30 slots for preventive medicine residency programs on the table for 4 of your biggest institutions and the state health department. And I think our pool of med students coming into preventive medicine in particular are incredibly diverse, and it offers an incredible pathway to fill those gaps in population health at health systems as well as health departments and at the whole range of the ecosystem of the health infrastructure.
You're right. That is a compound question.
I had too much coffee this morning already.
Well, you're going to get my bias, and that is on the issue of what I would say are the 5 most important areas to focus on. On working on the issue of diversity over these years, we continue to come back to the challenge, which is that so many getting a more diverse health workforce requires early investment in pre-K education, much more targeted outreach and engagement and support of people in our low-income communities. I didn't cover a range of other data that has to do with the maldistribution of K through 12 resources in so many of our communities. The educational funding is in public schools is if you are in a suburban area, the expectation is that the middle and more affluent communities will provide additional support for the schools. People pay $2,000, $3,000, $4,000, $5,000 per household to support the schools. That, of course, is not income that is available in low-income communities. And so many of our public schools have become the most segregated institutions in our communities. So, and most of them are 80 to 90% of the children are in federal school lunch programs, is an indicator of the inequities that we have. So investment in that arena is critically important. I would say a significant focus for me is in how do we, at the same time we're grappling with how to move out of our legacy model of healthcare delivery. We continue to hear from the employers that they're getting folks who are graduating from programs without an understanding of what the kind of transformation we're talking about looks like. One of our recommendations that was right on the bubble of priorities was fully integrating the social determinants of health into all of our health professions, education institutions, not as a course, but as an ongoing part of the educational process. We clearly need to have much more focused training of folks in the communities and ways in which to provide the support systems for our provider community to practice more in our rural and inner city communities. We simply are not giving enough attention to that process. And I would call for substantial increases in funding for government, public health, and others, with a focus on how do we get out of the categorical program box and really free them up to work in a much more dynamic way with a broad spectrum of stakeholders. We simply can't continue to reduce funds and tie their hands and say, why aren't you doing the things that we want you to do?
Thank you.
Yeah.
Sanne Magnan, Kevin, thank you so much. You are right in the middle of it. I was delighted to see under the healthcare workforce, expanding that capacity, that there was a diversity of types of people that you had said, including nurse practitioners, that you didn't start off with, let's increase more primary care doctors, but to look at expanding, scaling nurse practitioners, primary care, and psychiatry, and the community health workforce in its varied forms. My question is, did it come up about, we have a huge baby boomer bubble moving through that have a lot of capacity, a lot of lay people in a community. Did that come up about how do we capitalize on a changing workforce with the baby boomers and with a lay workforce to address population health improvement? Yeah,
that's a great question, and yes, it did, and you'll see it in a number of the recommendations. In fact, as we look at the significant numbers, increase in home care workers, as well as in other areas, the recognition that there are many folks who are of retirement age who are still quite healthy and welcome the opportunity to get in and roll up their sleeves and work, and everything from working in the home care arena to looking at other ways in which to support health improvement strategies in local communities, to mentor young people to do all of these things. This is, I would expect, to be a part of the continuing efforts going forward. Again, these were issues that we discussed. You mentioned looking beyond the physician population, and you'll see there's a strong emphasis on nurse practitioners. We have continued to come up against this issue of getting nurse practitioners full practice authority in California, as has been the case in 22 other states. And when you look at access to those services, it just, and you look at all the studies of quality, this is something that we should do. But we have been at every step of the way, a number of our major stakeholder associations have said, no, this will not happen. But it has been introduced. One of our commission members has introduced a bill to move in that direction. I mention it in part because we had discussions also about physicians' assistants as being playing a critical role of that. And again, and I did mention this earlier, a real driving force why we had such a short time frame was the commitment was to get this report out with the incoming new governor and his transition team, and to ensure that we had engagement early on in how to move some of this forward. So again, it's the acknowledgement, some of these issues we have to come back to. It's why you'll see in a number of the recommendations involve establishing state committees that are intended to be inclusive in terms of the participation, to flesh out some of these issues and ensure that things don't get left behind. Hi.
Hi, my name is Nguyen Minh Chau. Chau is my last name. I'm Vietnamese, but I don't use the Nguyen.
Okay.
I'm a former member of the Commission on Aging of Montgomery County, Maryland. And the projection in this area is by the year 20,000. I think one of those dates you dealt with up there. The population in this area would be 65% would be in the aging group. In your state, what kind of plans have you been taking or planning to do to plan for these aging people so that as they approach retirement, they do a good preparation for their retirement, but before that, to be fully productive in society? Thank you.
Could you repeat the last part of that question? I didn't hear. I'm a little hard of hearing myself.
Maybe I didn't speak into the microphone. The projection is by the year 20,000, 65% of the population in this area would be in the aging group or in the aged. I would like to know in your state, what kind of plans have you taken or what you're planning to do to prepare these people for their retirement and in terms of workforce? And second, how do you plan for their retirement and still being productive to society from a workforce standpoint?
And I think we just talked a little bit about we're thinking actively about the engagement of many of our folks that are at or entering retirement age in the workforce itself. And we had a number of aging experts that talked about this as a critical part of the path forward. And there are a number of recommendations that address this issue. But I will tell you that in response to your question, we have not done enough yet on this issue. As it relates to the home care worker recommendation, you'll see an important front-end analysis of that is to get a sense of what's the current capacity of our institutional structures, because clearly we don't have enough, and we won't be able to afford to institutionalize folks. Set aside the fact that that's not what people want. Over 3/4 of seniors across the country want to age in place. And so it makes both monetary sense and humanitarian sense to focus on how we do that. But there's an immense amount of work that wasn't outlined specifically in this report that we have before us. That was a part of the discussions of the aging subcommittee throughout the process. But folks recognize that there's a lot of work left to do as we look at this silver tsunami approaching.
I am so sorry. We're going to have to cut this off. I think we could fill the whole morning with talking to you about what you have learned. But please join me in thanking Kevin.